And good evening, everyone, and welcome to the Oculus Clinical Webinar Series. I'm Dr. Bill Tulo, Chief Medical Officer of Oculus, Inc., and I'm really excited tonight to have Dr. Stephen Greenstein talk to us about advancing keratoconus management with CTAK with the Oculus Pentacam. Before I introduce Dr. Greenstein, a little bit of comments. If you guys have questions, please put them in the chat. The more questions we have, the better everything is. We'll save the questions to the end, and we'll answer as many of them as we can. Dr. Stephen Greenstein is a graduate of Harvard Medical School's Corneal Refractive and External Disease Fellowship at the Massachusetts Eye and Ear Infirmary. He's currently medical director at the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus. He's authored many articles and book chapters on corneal cross-linking and is a co-inventor of Corneal Tissue Addition Keratoplasty, or CTAK. Dr. Greenstein is board certified in ophthalmology and refractive surgery and is a clinical assistant professor at Rutgers, New Jersey Medical School. He's a member of several ophthalmology societies and serves as an ophthalmologist for the New York Jets football team. With no further ado, Dr. Stephen Greenstein, take it away.
Thank you very much, Dr. Tulo. Welcome everyone tonight to a webinar that is near and dear to my heart, talking about advancing keratoconus management, in particular the new CTAK procedure, which is becoming more and more available around the US, and particularly how we are using the Pentacam as well to really enhance our CTAK results. So diving right in, where does CTAK fit in our keratoconus management? So I always like to think of modern keratoconus management as breaking down into three categories. The procedures for stability, which primarily is corneal cross-linking, the procedures which are used to improve corneal curvature and improve topography, and then at the end of the day, with all of the procedures that we do, we have to pick the best modality for our patients to improve their vision. And CTAK falls into the category of our curvature and topography improving procedures, which, as you'll see, has had remarkable results for patients' visual acuity as well. So how did we get here? How did CTAK start? So CTAK has been developed and refined over the past 7, now going on 8 years. The first case was done by Dr. Peter Hirsch at our center in 2016. And at the time, CTAK really took the form of placing lenticules that were shaped with the excimer laser in a pocket within the cornea to reshape and improve corneal topography. And as you can see in the pictures below, we really were able to get a very impressive amount of flattening with these lenticules. And we were really excited about the corneal topography that we were able to see postoperatively. But one of the things that we found over time was that the visual acuity for our patients really didn't match the topographies that we were seeing. And we couldn't really counter the interface and the interface haze that we were getting with placing these lenticules in a pocket. So we moved to visual axis sparing lenticules. So initially we were placing full 360-degree lenticules that we had basically punched out the center and created a donut shape. And all of a sudden we started to see better topography results. And at that point, we were starting to see the visual acuity reflect what we were seeing in the topography. As time went on, we started to customize these inlays to be able to adjust the parameters so that we could get even more reproducible topography over time. So CTAK inlays are really a combination of using a inlay that is gamma irradiated and sterilized, which is produced by CorneaGen. Once the inlay is gamma irradiated, it can be stored for 2 years. It has a shelf life of 2 years. And then we prepare these inlays with a femtosecond laser at the CorneaGen facility using the Z8 laser from Zemer. But really what separates CTAK is the process of going from a patient's corneal topography to cutting the inlay with the femtosecond laser, customizing that inlay based on the corneal topography, the width, the thickness, the arc length, and then providing each surgeon with an individualized surgical plan for each patient to place these inlays. So does this all matter? Does it matter to cut these inlays with the femto? Does it help with the results? So first, on the left, you can see one of the early inlays that we had done with a manual tree fine. And this is about 1 year after the inlay was placed. On the right, you can see the CTAK inlays, which we now place with the femtosecond laser. And even with the gamma irradiation process, you can see how remarkably clear these inlays are. At 1 year, they're actually pretty hard to see, even in the photograph that you see here on the right. So how are we doing this? How are we creating the surgical plan? So right now, this is where the Pentacam really shines because we are able to take the corneal tomography from a Pentacam device, and we have created a uploading software where you can upload the needed files directly from your Pentacam, and that will then go to CorneaGen where a surgical plan will be developed. And it's really as simple as what I show here, which is there's the external software portion on the Pentacam, which we have a few different softwares that we have listed there. One of the buttons that you'll end up seeing when you load the uploading software on your Pentacam is one that's called CTAK. Once you click that button, basically asks to accept the disclaimer, and then you're brought to the uploading software. The uploading software already has a scan timestamp for the image that was taken. You have to answer a few questions about the patient, most notably, do they have a history of refractive surgery, LASIK or PRK? We'll talk about a little later how that might change some of the parameters for a CTAK inlay and some of the things that you have to look out for that. Usually your clinic information will already be preloaded into the software. And really all you have to do at that point is click at the bottom left, upload scan. And within less than a minute, the scan is uploaded to CorneaGen to make a surgical plan. So it is really very, very simple to do once it's set up. Now, one of the things that is key, though, is making sure before you upload a plan that you really do have an adequate scan. And we don't demand that the scans all have an okay in terms of the quality of each scan that you take. As we all know from doing scans on keratoconus patients, as keratoconus becomes more severe, it becomes increasingly difficult and challenging to really get a scan that has the quality of okay. And we can work with scans that have multiple of the errors that you might see on the Pentacam. But one of the key things that we need to be checked before uploading a scan is really the iris image. And now most Pentacams come with the iris camera already built in. Some Pentacams, if you don't have an iris camera, can be retrofit with one. But an iris camera is really necessary to do and get an accurate surgical plan for CTAK. And you can see why. Because once you can see the iris image, once you look at the image, you can really tell whether or not you have adequate exposure. And that's one of the determining factors, particularly exposure of the pupil, that allows us to plan adequately for the CTAK inlay. You can see that on the picture on the left and the picture on the right, even though we actually have the same data gap error, one is capturing a full blink, and one has good exposure with the full pupil that you can see. Obviously, the picture on the right, we really can't plan the placement of the inlay relative to the pupil, whereas the picture on the left, it's no problem. So it's one of the things that you do want to check. We're not accustomed to always looking at that iris image when we take a Pentacam, and make sure that's clear before you upload the data. Once you upload the data, you then receive back from CorneaGen a surgical plan. And we're going to go through in detail the different aspects of the plan that you receive. But each of these plans are customized, and each of these plans are based off of the Pentacam scan that you send. So you do want to get the best scan possible for each patient before you determine which one that you want to send. So for patient selection, we recommend starting usually in moderate keratoconus, but we have a pretty wide range when we talk about moderate keratoconus. We say to start somewhere in the 50 to 75 diopter range. So I think most of us would agree that 75 diopters is probably hard to categorize as moderate keratoconus, but we've seen CTAK work very well in these cases. We have used CTAK in more mild cases and in more severe cases. But those need to be done with a little bit more planning and sometimes a little bit more back and forth conversation about what the goals are for each of those patients. One of the key things, especially in more mild cases, is the patients do have to have an irregular astigmatism. That is really what CTAK is designed to treat. We have to be more careful with patients with ectasia, particularly ectasia after LASIK, and navigating the LASIK flap. I'll go through a few different tidbits for that later in this presentation. I definitely would not recommend starting with ectasia cases. You really do want, even if you're well-versed in placing intacs segments or other corneal ring segments, you do want to get a feel for the corneal inlays. You do want to get a feel for CTAK and placing it before navigating around a LASIK flap. Moderate-sized cones tend to work the best, so cones that are around 5 millimeters or less in width. You can certainly do it on ones that are larger. And then really you want to keep the cone to get the best results. You want cones that do fall in the central 6 millimeter optical zone, which most true keratoconus cones do. Again, you can use it for more peripheral cones, but a more manual planning sometimes is needed for that. And because we are sparing the visual axis with these cases, you want to avoid scarring in the visual axis as much as possible. All of these rules can be bent, and I'm going to show different cases where that was done, but these are definitely the best starting rules to go by when trying to pick the first cases to do CTAK. In addition, there's a specially designed CTAK instrument set, which is provided by Corza. And the CTAK set in particular comes with two features that are really three features that are very important for successful CTAK outcomes. The first is the marking set. We'll go over in some detail why corneal marking is so important for placing the CTAK inlays in the right position. The next is the CTAK forceps, which are really designed to hold the inlay. The inlay, it has a certain amount of integrity to it from the gamma irradiation process. But even with that integrity, you really do need a forceps that have the right curvature to fit within the channel and still adequately hold the tissue as you place it through the channel. And these CTAK forceps are designed to do that. There's a spatula to open incisions, very similar to LASIK dissection instruments. And then the channel dissectors, which you see down below on the bottom right. Anyone who has done intacs in the past with before the femtosecond laser was creating the channels knows about using instruments that manually would dissect the channel to place those intacs segments. So similarly in CTAK, you have to dissect the channels fully to be able to place a CTAK inlay successfully. The inlay has a certain amount of integrity to it, but it does not have enough rigidity to break adhesions in the channel. So you do have to break those adhesions as you would dissecting a LASIK flap before you can actually place the inlay. And these dissectors are designed to fit through the CTAK channels and dissect both to the right and to the left to fully open the channel before placing the inlay. In addition, there's a manipulator that helps you move the CTAK inlay around and an applinator to smooth it out. And I'll have some videos where we can take a look at all of that a little bit later. So as I said, we're going to come back to the marking. The marking for CTAK inlays is critical because we are not centering the inlays around the pupil. The inlays need to be centered around the cone, around the steep area of the keratoconic cornea. And when you use the femto laser, by default, we are used to centering our laser cuts around the pupil. So particularly, of course, when we do LASIK and we're trying to center a LASIK flap, we will make sure that the flap is more centered around the pupil than centered around the center of the cornea itself. So the pupil is the easiest landmark to see under the femto laser, but it's actually not the accurate landmark to place CTAK inlays. So we developed a marking set which allows you to mark the cornea and create almost a new pupil, a new optical zone. And it is that mark that we then rely on to decenter the lasers and cut the channels in the proper position. And we have a marking set that generally goes from about 1.5 millimeters to 3.5 millimeters. And the key is that it goes in 1/4 millimeter steps. So there's really no caliper that's designed to go in such small increments from the center of the pupil to each mark. And I generally actually just mark temporally and inferiorly. I don't usually mark the inferotemporal, but that measurement is given. Now you'll notice on the surgical plan, you get an incredibly accurate measurement. So in this case, we're being told to decenter 2.08 millimeters from the center of the pupil inferiorly, and a similar 2.08 millimeters temporally. Obviously, we don't have marking sets that go to that degree of accuracy, so we go with the nearest 1/4 millimeter, usually rounding up, so rounding so that the marking is slightly more peripheral. We'd rather err these inlays to be slightly more peripheral than slightly more central, because they are already being placed very centrally, and we do want to keep them a decent enough distance from the pupil. So and we don't want to have them placed where they go over the steep axis. We want them to be placed around the steep axis. So generally you want to err a little bit towards the periphery. So in this case, I would usually mark with the 2.25 marker, and then know that I could just maybe move the femto laser slightly inside my mark. Once you have your inferior and your temporal mark, and then your inferior temporal mark, if you want to use that, then you will take the optical zone marker, which generally is going to be 4 or 4.5 millimeters, could be as wide as 5, and you want to encompass the marks as best you can. So you want to try to take your optical zone marker, encompass those marks, and that now becomes the new area that you're going to focus the laser on to create your channel. So here's one example of decentering, trying to follow that violet mark that we've now made on the cornea. Once we find that mark, we can then create the channel. And in this case, with the Z8 laser, we can make a channel that is exactly to the specifications of a CTAK inlay with an incision on both sides to help us manipulate that inlay. It is not necessary to make a channel that is specific to the exact dimension of the inlay. You can definitely make a 360-degree channel, which is what most femtosecond lasers will do, and the CTAK inlay will work just fine. So here's another example where I used the IFS laser from Johnson & Johnson, and here you do have to make a 360-degree channel, which works fine. One of the keys is, you can see, and I kind of tried to highlight it with the violet mark here, so you can see how decentered this cone is. So here we are really decentering our cut from the pupil. And when you start to see that under the microscope with the camera, it starts to feel somewhat uncomfortable that you're really moving this inlay so far from the pupil. But as I've learned over time, you really, really do want to trust these marks. Your mark tends to be more correct than the pupil. So Anytime I tried to move it slightly more towards the pupil because I thought it was too decentered, I regretted it. I thought the mark was actually more accurate. So you really do want to follow your mark. And as you can see here, we are creating a channel that is fairly decentered here, but in the perfect spot to place a CTAK inlay. The next step to the procedure is actually unloading the inlay, which you get which comes in a vial. If anyone does ICL, it's a very similar vial to the vial that the ICL comes in. And then you're provided with this strainer, which allows you to pour the albumin with the inlay into the strainer, hopefully secure the inlay in the strainer, rinse it with BSS, and then you're ready to move forward and to do the CTAK procedure. It is very common that the inlay does not come out of the vial right away. Sometimes if you tap the bottom first, it can help a little bit, but it is not uncommon that you have to find the inlay in that bottle after releasing the albumin. So very important not to throw anything out, including the cap, before you've actually identified where the inlay is. And generally, if it is still in the vial, I just take a Wexel and I use the Wexel to bring it out of the vial once I find it. These inlays are pretty small. I know that Dr. Wiley, who had done this, suggested using the ICL forceps, which I think is a great idea, to take the inlay out as well. So either way is fine, but you do want to make sure that you have found the inlay, you've secured the inlay before obviously disposing of anything that the inlay has come in. And then again, you want to rinse the inlay with some BSS, and then it is pretty much ready to go. So the nice thing about CTAK inlays is that because they already have, as I said, some integrity to them, they have some rigidity from the gamma irradiation process. There's no dehydrating of the cornea. You don't have to wait 45 minutes or an hour for the cornea to dehydrate to be able to place it within the channel. You can very easily place it within the channel right after you rinse it off. So here is the procedure being done. Again, that's the mark. So in this case, that's a 4.5 millimeter mark. I showed already the laser cuts being done, but this is the laser cut being created. Again, we open, in this case, I've made 2 incisions because I didn't make a 360-degree channel. So we use the dissector to open up each incision. If you have a LASIK dissector, it works very well to do this because the channels are 200 they're 200 microns at depth, so they are pretty they are much more interior than we place intacts. Then you can place the inlay by lifting the incision with a straight forceps, usually without teeth. Slide the inlay right underneath and into the channel. You can push it a little bit with the CTAK forceps, and then you can take the manipulating instrument and right here, and if you can bring it around the other side to get it into final position, with then the applinator at the end to smooth out the inlay, very much like you would smooth out a DMEC or something, or a DSEC procedure. Here you can very nicely from up top smooth out the inlay, and actually that allows you to not have to have the inlay reach all the way to the second edge by pushing or pulling. Usually if you can get the inlay around the final turn, you can actually just smooth it out the rest of the way, which particularly when you have a 360-degree channel and you might have to reach a much longer way, let's say counterclockwise here, to reach the inlay and pull it, frequently you can just smooth it out and get it right to where it needs to go. So it's this ability to take the tomography scans, to take the scans from the Pentacam, to then generate that surgical plan, and then use that surgical plan to guide our placement of the inlays, which have really led us to be able to achieve these reproducible results. And you can see that in the top left, we're looking at a much more severe case of keratoconus, somewhere around 66 diopters. And in the bottom left, a much more mild case of keratoconus, where the Kmax is probably somewhere around 49 diopters. And that customized flattening and placement is what allows you to get that really reproducible, much more regular central astigmatism that you can see in both eyes, on the top and the bottom in the center. And that's really what we're going for. And that's why it is so critical to get that map with the adequate iris image off of the Pentacam, so that you can you can adequately plan and get these type of results. So we published on the first set of a prospective trial that we had done, open label, with 21 eyes of 18 patients, and fortunately we were featured on the Journal of Cataract and Refractive Surgery cover. This was in July of 2023. And these were the results that we were seeing at that point. So it's important to note that this trial was done on more severe patients. So you can see that the average uncorrected visual acuity was a logMAR over 1. So it was 1.21, which was about a Snellen acuity of 20 over 237. So these are really much more severe cases. And we saw an average improvement of almost 6 lines of vision with the CTAK inlay. And you can see that when we broke it down among individual patients, there were 10 patients of the 21 that had more than 6 lines of uncorrected visual acuity. So there's really nothing available for keratoconus management that can give you those kind of results. When we looked at spectacle correction, when we looked at corrected distance visual acuity, we saw an average improvement of about 3 lines of vision. And when you look at other alternatives like corneal ring segments, really the average improvement that most studies will report on for corrected visual acuity is somewhere around 1 line. Sometimes you get a little bit more, sometimes you get a little bit less. But this is really 3 times that number. And you can see that we were taking patients' spectacle vision from around 20/80 and bringing it down to 20/40. So this is a real meaningful difference for these patients. 20/40 vision in glasses is a much more functional vision. Now, it's important to note that most of these patients, especially with their more moderate and severe keratoconus, they still wore contact lenses, and many of them still wore scleral contact lenses to get their best vision throughout the day. But as we know over time, even for our scleral lens wearers who do wear their lenses 14, 16, some even 18 hours a day, over time that becomes more and more intolerable. But they do it because they're not functional at all without their contact lenses. And if we can make those patients much more functional, where they can feel comfortable walking around their house in glasses, taking their contacts out for a weekend, it can really extend their ability to wear their contact lenses over the long term. In this study, we did have one patient who did worsen by 2 lines, and they did have a channel tear that needed to be repaired. Fortunately, their scleral lens vision remained the same. But their uncorrected vision remained the same, but their spectacle correction did get worse, and I'll go into that a little bit later as well. Again, this is something that we really don't see with most keratoconus treatments that we have available, and that is a real meaningful change in a patient's manifest refraction. And you can see here that with the spherical equivalent, we are really bringing these patients much, much closer to plano. And over a 6-month stretch, that spherical equivalent remained remarkably stable over time. So this is why patients are really noticing that incredible change in both their uncorrected vision and their spectacle correction. And finally, when it comes to flattening, so with CTAK inlays, Maximum keratometry turns out to not probably be the most important indicator of flattening in these patients. First of all, it's a point that can sometimes move around, especially in a more moderate and severe case of keratoconus just in general. But a lot of times with the CTAK inlay, because the actual cornea over the CTAK inlay is steeper, the maximum keratometry tends to move. And there were certain cases where we were actually measuring the maximum keratometry somewhat close or right at the border of the CTAK inlay itself. And that wasn't relevant to the patient's vision, and it wasn't reflective of the actual steepest point flattening. So probably mean keratometry for CTAK is the more meaningful flattening, but mean keratometry flattened by close to 8.5 diopters with the maximum keratometry close to 7, although that had a lot of variability to it. In terms of a maximum flattening, so how much was the most flattening we were seeing in each patient, that was around 16 diopters out to 6 months. But the real key to CTAK is not getting maximum flattening, it's getting customized flattening. So what we really want to see is we want to be able to get the flattening that we need based off of the severity of keratoconus. And you can see how wide range the flattening we were able to get was in these 21 patients. So our flattening ranged anywhere from close to 4 diopters of flattening to almost as much as 30 diopters of flattening, with everything really in between. And if you look at the bottom, again, when you look at the mild, moderate, and severe cases, what I want to really draw your attention to is that post-op central regular astigmatism that you're reproducibly seeing in each level of keratoconus. So whether we're getting the 4.5 diopters of flattening in the mild case or 24 diopters of flattening in a more severe case, we really are looking for that regular, more symmetrical astigmatism in the center, and that is what's giving our patients the visual acuity results that we're seeing. We're hoping to present on actually a lot more eyes at ASCRS coming up in the spring, and I can tell you somewhat hot off the press that the numbers that we are seeing in these eyes are very, very similar to this clinical trial. So it's been nice to see that as we've continued to do this, we are seeing very, very similar visual acuity numbers, as well as some other clinics who have started to present on their data at different meetings have also started to show very, very similar results. So I want to walk through a couple of cases to highlight how we're using CTAK, some of the things to watch out for with CTAK, and then definitely answer any questions that people have about the CTAK procedure. So the first case here was a 35-year-old female. Now she had a transplant done in her right eye, which actually had a rejection episode, which was fortunately reversed with topical steroids. But now she was complaining of a worsening vision in her left eye, and she was having a lot of difficulty with contact lenses. She worked for an airline. She was a stewardess, so she really had trouble wearing the lenses for long hours, especially up in the air. And so she really did not want to do another transplant given the rejection that she had on the first one, and the need for sort of at that point using a more chronic steroid in that eye. So we offered her to do CTAK to try to improve her vision. And if you look at her starting topography on the left side, there's really nothing besides corneal transplant that you could offer this patient that is going to help her situation. Clearly, scleral lenses she should do well in, and she was doing pretty well in contacts in terms of vision. But if you're trying to reduce her need for those lenses, there's really nothing to offer her short of at least a DALK, if not a PK. So her pre-op vision uncorrected was counting fingers. Her best corrected vision, her glasses, is 20/70. So it's very, very clear why she's very reliant on her contact lenses with a high myopic astigmatic refraction. So we placed a CTAK inlay. Again, I draw your attention at the risk of being repetitive, but really looking at that post-op flattening right in the center of the cornea with a much more regular astigmatism. And now 3 months later, her uncorrected vision is 20/60. Her spectacle corrected vision is almost 20/25, 20/30 plus 2, with a much more manageable manifest refraction. And when we put her two eyes together, we can really see that her CTAK is performing as well and maybe even slightly better than her corneal transplant. And she can wear glasses now much more functionally in both eyes. She no longer has significant anisometropia. Her spectacle correction is pretty even between the two eyes. And for a 35-year-old to be able to save them from having to do a transplant is a really, really meaningful procedure for their long-term quality of life. This was a more mild cases, a moderate and more mild case of CTAK. And this is actually a brother and sister who each had a CTAK done about a month apart. The brother was in the top, the sister at the bottom. And in the sister's case, she had actually had a pretty significant progression. She over about a 2-year span. So she did not choose to move forward with cross-linking when she was initially seen, had been lost to follow-up, and then came back only when she started to lose vision in her right eye, and she had a fairly significant progression. So we offered her to do CTAK in combination with cross-linking, which we are usually primarily doing simultaneously now. We place the CTAK inlay first, and then we do cross-linking afterwards. But we did both. And again, you can see that the moderate case in the for the brother and the little bit more mild case in the sister's case, but it's really getting the flattening in the right area for each patient with the right amount of flattening to get the visual results that we're looking for. And really both did amazingly well, both with a glasses correction almost identical of 20/25 plus and 20/25 plus 2, and uncorrected vision in the brother's case where he really didn't even feel like he needed his glasses at all. And for the sister, she was able to wear a small pair of glasses and actually wear a soft contact lens, which she was very happy with as well. So it's really the ability, again, to take these maps and be able to get that accurate plan that allows us to get these kind of results. Additionally, just with cross-linking, we've done CTAK now on multiple patients who had previous cross-linking done. As I said, now we mostly do them simultaneously, and I have not encountered any additional difficulty placing them or dissecting channels in patients who have had previous cross-linking done. So here's another case. This was a 38-year-old. He had had a transplant done in the left eye and then had intacts placed actually by us in the right eye. But he was really complaining that his vision was poor in the right eye and had remained poor after the intacts was placed. So his left eye is the eye that has the transplant. He's doing pretty well in glasses. He does have a lot of astigmatism in his correction. And then in the right eye, he's not doing nearly as well. Counting fingers of uncorrected vision, his glasses vision is 2400, and he's very anisometropic from all of that as well. So you can see why he's not particularly happy after the intacts, because it really made no difference. If anything, he would probably argue maybe he's even slightly worse from it. His uncorrected vision is unchanged. His glasses correction actually maybe is a little bit worse, and he's much more myopic with more astigmatic correction. So he didn't obviously, and correctly so, didn't think that the Intacts were very valuable. So normally in a patient like this, we would really just offer them to remove the Intacts, and then they would need to move forward with a corneal transplant or contact lens fitting. So this was not his eye. I'll show you his eye after. But this was a similar way that his Intacts looked and his Intacts was placed. There was nothing wrong with the Intacts, we planned on removing it. Now, one of the things when you're going to remove the Intacts in these cases that you want to navigate is the incisions, because normally when I remove Intacts, I try to actually create an incision very close to the Intacts segment so that I don't have to really redissect through much of a channel. I'm usually able to use a Sinski, take advantage of the hole in the segment, and take the Intacts out through a very close incision, which makes the procedure much easier. But in the case of when you're going to plan on potentially doing a CTAK, you really have to think about where you want to place that incision to remove the Intact segment, because you really want to try to leave yourself with as much room as possible to be able to use as much of the area of the cornea that remains to place the CTAK inlay. So in this case, when I had seen what generally the plan was going to look like for when we were going to place a CTAK, I really wanted to keep as much corneal real estate as possible. And in these cases, it is worth taking some extra time to redissect through the previous Intacts channel to manipulate the segment out through an incision that's a little further away so that you can get a more full CTAK in when you do the procedure. And so this is what the cornea looked like. This was the actual patient once we had placed the CTAK inlay. And so he had a few different incisions that we had to manage, which is his original Intacts incision, the incision that I made to remove his Intacts, and then one final incision that the femto made to be able to place and manipulate the Intacts, the CTAK inlay once it was in the channel. So that's the one key when replacing CTAK with Intacts, is really maneuvering through the incisions. Now, with the Zemer, when I'm able to cut a particular length of a channel, we can navigate around the incisions that way. I've done it also with the IFS, where I made a 360-degree channel. I will not place the CTAK inlay through any of the areas of the previous incision. So we'll start with the incision on the other side of the cornea, usually place the CTAK inlay up to the previous incisions, but not through them. So now you can see the difference for this patient. So now his right eye after Intacts was counting fingers, 2,400 with a high myopic astigmatic correction. And now after the CTAK, his uncorrected vision is somewhat better, but his spectacle corrected vision is much better and a much more manageable refraction. So again, even if a patient like this does choose to wear a contact lens to get their best vision, this is a much, much more manageable vision for this patient. And I have done this in 3 different patients where I took out their Intacts and replaced them with CTAK. All patients who really didn't get an Intacts result that they were looking for. And you can see that pretty much they were very similar cases. Their uncorrected vision really didn't change from placing the Intacts almost at all. And in most cases, their spectacle correction didn't change, or as I showed you in the first case, it actually got slightly worse. But you can see after CTAK, particularly in that spectacle correction, how these surgical plans are allowing us to get these results, which is the uncorrected vision improved in most cases where patients really could notice the difference, but the spectacle correction really improved to a level in 2 out of 3 cases to around a 20/40 spectacle correction, which is a very functional vision for these patients when they don't wear their contact lenses. So again, you can see the difference in the power that you're getting from the CTAK inlay over the intact segment. And this is that one of the patients, this was the second case of the three that I showed, where you can see the intacts got about 7 diopters of flattening and in the right location, but in that level of keratoconus, it's just not enough. And then that same patient, we're getting 18 diopters of flattening, even more centrally, and then you're seeing much more improvement in the patient's vision. The other nice thing about the CTAK inlays is that they really do take on the natural contour in the periphery of the cornea. So one of the things that's very difficult with intacts is that the intacts segments will raise the cornea. That's how it induces the flattening. And you get this kind of elevated area in the mid-periphery and periphery of the cornea, which, as you can see on these Scheimpflug images here, with the CTAK inlay, you really don't get it all. And this is very, very helpful for our optometry colleagues when they're fitting contact lenses, because one of the most difficult things about fitting gas permeable lenses and any really rigid lens around the intacts is that you need to avoid getting a rubbing against that intact segment, because that's when we see complications like extrusion. But with the CTAK inlays, and Dr. Gelles has fit multiple lenses over our CTAK patients, he really will say that there's no adjustment that you need to make in the periphery of a fitting after the CTAK inlay is placed. Because it really maintains that natural peripheral contour, the contact lens fitting really is much, much easier for these patients. So they're getting better specular correction, and they still can wear their contact lenses comfortably with very good correction as well. So the last two things I wanted to highlight is, as I said, we were going to circle back to, is ectasia after LASIK. Now, ectasia after LASIK leaves certain challenges when it comes to CTAK. First of all, these patients are already pretty thin. They're thin from having their excimer ablation done. And so these inlays sit much closer to the center of the cornea than than a corneal ring segment does. And so you really have to make sure that there is adequate thickness in the area that you are going to place the inlay to be able to place a CTAK inlay. In addition, you really have to navigate the LASIK flap, because you're placing these inlays much more anterior in the cornea. That's part of what's giving its effect than you do the corneal ring segments. And these inlays are generally placed about 200 microns deep. With ectasia, we always place them at least 250 microns deep. So we always add an additional 50 microns. But you really need to make sure the depth of the LASIK flaps before you do this. And here's an example of an older microkeratome flap with a patient who has some epihypertrophy. So I don't know if it was a 200 micron deep flap, but it was clearly a fairly deep flap that was made. And at this point on the OCT, it measures about 200 microns in depth. Now, if we place a CTAK channel right at that same depth, we're just going to be placing the inlay right under the flap. So you need to really make sure that you can determine the depth of these flaps to be able to navigate the CTAK inlay properly, and to make sure that the patient is an adequate candidate with adequate thickness to place. If you have an OCT that you can scan with your femto laser, that always gives an extra kind of added security to determine the depth that your channel is going to be created. But at a minimum, you need to make sure that you have a general sense of the depth of the LASIK flap before creating a channel. And here's an example of a case of ectasia after LASIK, which I had done. And because you are very close to the depth of the LASIK flap, it is very possible to be in the LASIK flap interface. And I don't know how many people could see, but I was able to see already that my dissector was really moving past my mark, and I began to realize I was in the LASIK flap. So I came out, redissected, and you know that you're definitely not in the LASIK flap and you're in the channel, but because you can see once you're in the channel, look how much pressure I can put on that channel, and the dissector isn't going anywhere. So it's really, the key is navigating to make sure that this larger piece of tissue, that your dissections are really happening in the right plane. Once you're in the right plane, then it does become like a regular CTAK procedure. The flaps don't lift when you place them in. You can manipulate the inlay around the channel, so you can place it both with the forceps. You can pull the inlay around, and you can do the smoothing over the top to get the same results. So I definitely don't recommend starting with ectasia cases because you do have to get a feel for the instruments and placing these inlays before you do them. You really have to make sure that you have adequate imaging before doing them to make sure that you can really identify the depth of the LASIK flaps, to make sure that they really aren't too deep. And if they are, you have to make sure you have enough thickness to be able to place your channel deep enough. And then once you're in the procedure, it is very, very important at every step to make sure that you are in the right plane and the right channel, in the dissection and in the placement. I've had also, even with good dissection, the inlay placed under the flap, had to take it out, put it back in the channel. Patients did well. Fortunately, I haven't had a flap lift up where I needed to suture it down or anything like that. But you want to make sure that you're definitely in the right plane. Now, one of the things that I haven't seen as much since we developed the instrument set specific for CTAK are tears within the channel. Now, again, one of the nice things about using a corneal inlay is that whereas in a corneal ring segment, in a synthetic ring procedure, where anytime you had any kind of tear in a channel, you pretty much have to abort the procedure. With these inlays, you can many times navigate around a small tear if you do get it. You can do it by stitching down the area and leaving the CTAK inlays sometimes just short of the area of the tear. So you can use a Westcott and cut them a little bit shorter. And sometimes you can get them in at their full length, because the most common place that you get the tear, if you're going to get it, is usually at the incision edge. If there's too much manipulation coming around the turns, you can sometimes see that edge lift, and usually you can get the CTAK inlay into position and then just suture that area. I did have one case where unfortunately the channel tear was too large, and I didn't feel comfortable that I can get the CTAK inlay in any meaningful way. But like I said, now with the CTAK instruments, fortunately, these channel tears are very rare, and if they're small, you can still successfully complete the procedure. Now, one last case is for corneal scarring. So as I said at the beginning, generally, if there's scarring in the visual axis, you want to avoid a CTAK because you aren't going to do anything about that scarring. I have found that in some cases, even with what looks like fairly visually significant corneal scarring, the CTAK inlay can actually still work very well. Usually the best indicator to this is if the patient has a pretty decent contact lens RGP over refraction, then likely their scarring is not over their visual axis to the point where at that point they would need some form of transplant. And many of those patients can still benefit from a CTAK procedure. So this was a 26-year-old who wears scleral lenses all day because his best vision in glasses is 2200, and he was really looking for something where he could reduce his scleral lens need as much as possible. And I had told him that he had a pretty significant amount of scarring. His options were to do a corneal transplant, which for a 26-year-old means that they're going to have that, as we know, for life, and that comes with certain risks that exist throughout life. When you need it, obviously we do it, but if we can avoid it, we try to do that as well. So we talked about doing CTAK. I wasn't, even with his contact lens vision, I wasn't sure how well it would work, but he wanted to try. And you can see that with the CTAK inlay, again, we got a really central flattening with a really much more regular central astigmatism. And his uncorrected vision improved from 2400 to 2080. His spectral correction improved from 2200 to 2050. He still wore his scleral lenses during the day, which the vision didn't change. It remained 20/30. But his overall ability to function without his scleral lenses and his quality of life because of that was significantly improved. So even in some of the cases where early on we say to avoid it, or you have to think about it carefully, you could see that CTAK can still be a very powerful tool and a very powerful procedure for our keratoconus patients. So again, hopefully through this tonight, you're able to see really the process that has been developed from start to finish to allow you to use CTAK for your keratoconus patients. It starts with getting the best image that you can with the Pentacam tomographer, a good iris captured image, which then allows CorneaGen to customize a inlay based on each patient's tomography, and then provide you with a surgical plan so that you're able to place these inlays properly and in the right position to get these same results. So with that, I'll take any questions that are out there. Thank you very much.
Wow, fantastic, Steve. This really is incredible information, and what a difference from what we've been seeing with in the U.S. anyway, with the limitations of Intex. And I think you just answered the first question, but I'm going to ask you it anyway. It's that I guess the main restriction we've had in the U.S. with the one-size-fits-all Intex is overcome by this nomogram CorneaGen develops. And what are the variables? I think you mentioned the thickness, the arc length. Um, what are the variables are in the nomogram to determine what segment you're getting from them? Is there more than two variables, or?
Yeah, so there's going to be the width of the inlay itself, so the inner diameter to make sure that the width is wide enough to encompass as much of the cone as possible, the length of the inlay, and the thickness. Those are really the main variables that induce the flattening and the flattening in the right location. On the flip side, then you get the plan of how to place it relative to the center of the pupil.
Right, and the decentration, yeah,
Yep.
fantastic. You mentioned about the extrusion issue, which we've seen with Intex, not a rare occurrence. What about the glare issue? We had a lot of issues with glare and halos with Intex that were properly placed. Do you see glare and halos much after the CTAC placement?
So yeah, so surprisingly not. We are placing these pretty close to the pupil, and overall, patients tend to report that things are much more singular, and they have much less glare. So I think that the CTAC inlay, because we are doing this on such aberrated corneas, the improvement of those aberrations is so much, and the images become, and the quality of the image generally become more singular, that patients seem to appreciate that more than any additional glare. They still may see some for sure, and see some at night, but we have not really had patients complaining of increased glare overall. I've had one patient who said that they sort of described seeing the edge of the inlay a bit at night, and that was the only one who actually made any reference to any kind of visual a symptom like that. Now, the one thing also is they are reversible. So if a patient, and patients are comforted by this, so if a patient really is bothered by whatever the symptom is, you can take the inlay out, and similar to Intex, it should go away. So I have exchanged a couple for different sizes, either thicker or thinner, and with a little bit of manipulation, it's actually pretty straightforward to be able to get them out.
You mentioned also in select patients that you would consider simultaneous CTAC with cross-linking. Can you elaborate a little bit on the form of cross-linking you would do? Are you putting riboflavin in the channels? Or are you doing standard Dresden protocol epi-off? Or what are you doing?
Yeah, so we do a couple of different things, but in general, we're doing the standard epi off cross-linking after the CTAC procedure. I don't put riboflavin in the channels. I don't. The main area that you need to cross-link is the cone itself. It is the thin, steep area in the cornea. And actually, the nice thing about CTAC is it kind of demarcates that area. So I actually will really just debride the epithelium up to the edge of the inlay, and then I do the cross-linking right in the center there. Most patients are choosing to do it simultaneously now for convenience because it is much easier. I do know that for a whole host of reasons, some of which being navigating CTAC in the OR with the cross-linking device being in a different facility, and potentially some billing reasons that they might be separated, but I haven't seen any benefit of separating them.
And the last question I have for you is when you compare CTAC to CARES procedure, it seems to me like this is a much more customizable procedure compared to CARES. Can you make any distinction between those two procedures and what the advantages you see with CTAC?
Yeah, I mean, I think that the differences are, and the procedures, there are many ways to do these type of procedures. I think the CTAC comes from a different background. So CTAC came more from a background of shaping inlays, and that original inlays that we were creating is really what sort of drove the future iterations in the CTAC that we do now, which is what created the topography plans, which we then now customize for those inlays. So they're much larger, wider segments that are placed much more centrally because of that. In addition, with the Pentacam and the ability to really take the data from the Pentacam and be able to provide this customized plan for each patient, I think the reproducibility of being able to use CTAC is easier to get started with because really it's all there for you. If you have the Pentacam, you can take the image, you're going to get the plan with the instruments, and you should be able to get these type of results.
Well, fantastic. This is really exciting information and something that our patients can truly benefit from. I want to thank you so much for sharing your knowledge with us tonight. And I want to thank everyone for attending. And I wish everyone a wonderful night. Thank you
Yeah,
so
thank
much.
you very much. Have a good night, everyone.